I am Dr. Inam Danish, as already introduced by the chair, and I would like to deliberate upon a concept paper. Not that I have got any actual experience in drones, but it's just a concept paper which can be applied in a real life scenario, as was what my predecessors have also been talking about. Right? I have nothing to declare, and let's start with this. So this scenario, what was there in the first slide, was actually a picture of the Hajj pilgrimage. And in 2016, I had a live experience working with the Hajj pilgrims in Saudi Arabia. And I would like to walk you through this experience. And I would like you all to engage with me in a thoughtful engagement that in which all scenarios we can apply these drones and how we can improve upon the overall Hajj operations, especially the healthcare operations. So I'm a medical doctor. So I will be talking about a lot of things about the medicine and evacuation and patients. So for those of you who are not accustomed to the medical terminologies, I beg my pardon. But otherwise, I would just like to keep it as simple as possible. So the Hajj is an annual mass gathering of 2 to 4 million pilgrims from about 200 nations. Right? The duration is about 45 days, and this happens in a harsh desert climate of Saudi Arabia. Right? In this 45 days, there are critical 5 days in which all these pilgrims, they stay in minimal clothing, in tents, or sometimes they are just in the open, they're unsheltered, right? The rituals in this Hajj pilgrimage are physically demanding, and there is a moving assemblage, which is very, very difficult to control on its own, as well as even by the best form of surveillance. I will show you a lot of pictures also. So I understand that for those of you who are new to this, it will be difficult to understand, but I'll show you a lot of photos as well. Then there are surging troops, right? And there are congregations of more than 9 people per meter square, right? All of this, culminating into a food, water, housing, transportation, crowd control, communication, sanitation, and overall security, challenges. And these challenges are multifolds because all these pilgrims are not from the same countries. They're not from the same region. They have different cultures. They have different languages. It's completely heterogeneous, right? Different kind of education. So all these things and we are talking about 2 to 4 million pilgrims at one place in one city, right? So this is how the Hajj is designed. So what happens is that the main city here is Makkah, which is labeled as 1. And here there is a grand mosque. Now, all these people will be here in this mosque, right? You can see that black structure inside is known as KAABA, right? And after that, they will move from here on foot to a place known as Mina, right? And they will do some rituals here. Then they will move, this is number 2, right? Then they will move to another place, which is known as Mount Arafat, right? It is in the Arafat Valley. So this terrain is desert terrain, as well as a lot of mountains, right? So what I'm trying to highlight to you is that in case we are trying to use drones, then we have to avoid these mountains also, and there will be a lot of dead space. So all these things will be there. So I just want you to keep thinking aloud that what are the challenges and how we can develop a solution, because I want you all to be participating in this, right? Then from 3, they come back to a place known as Muzdalifa, and this is number 4. And here they will do the stoning ceremony, and then they will come again back to Mina. This is number 5, and then finally they will come to Mecca. So it's not just at one place. The entire assemblage is moving as well. So what happens? So what happens is that what are the challenges? And I'll talk about only the healthcare challenges, since I am a medical doctor and I have experience on this. So there is very high morbidity and mortality. So morbidity is that the number of diseased people will be very, very high, and mortality is the death. So a lot of people will die because we're talking about 2 to 4 million pilgrims. In addition, there is a risk of disasters, stampedes, polytrauma, and disease outbreaks, right? So a shorter form of what we had as a COVID pandemic, there can be an epidemic there in the Hajj itself because of so much of overcrowding and so many people moving around. Then there are challenges to global health security, and there have been outbreaks of many diseases in many different years, right? And it's a mass gathering healthcare system. So we don't have very well established hospitals and operation theaters, and emergency response systems are not there as much. Most of this is the people are staying in tents, and a lot of these hospital and healthcare systems are also in tents, right? So basically it is a mission operation scenario. So we call it, so every country will establish its own Hajj medical mission. Like the India, it developed its own Hajj medical mission that has been running every year for every year's Hajj pilgrimage, and this will cater to the Indian pilgrims, right? So we'll come back to the details later. And there are challenges of healthcare accessibility and utilization, and there are a lot of ethno-linguistic and socio-cultural barriers to this. So see this. This is that grand mosque, and you can see in this is that KAABA, right? And you can see these crowds, right? And there is no space to stand or walk in this entire thing. Whatever the place is remaining, also that is also crowded. I will show you another picture here. You can see this is the kind of people who will be standing, and they're not wearing proper clothing also, and they're standing in sun. It's a desert climate, so they are very much prone to the heat effects of heat as well, right? Then you can see, so coming to the Indian Hajj medical mission. So it's an annual medical mission, and it caters to about 1 to 2 lakh Indian pilgrims every year. Approximately 150 doctors are deployed here, of which 50 are specialists, about 150 paramedics, and there are 75 or so ancillary personnel who are non-medical, but they support, right? Now, in 2016, there were 14 doctors in our team who were leading the entire contingent, right? And it was a limited resource, limited opportunity scenario. We didn't have anything to actually look after all these so many pilgrims, and we had to maintain a holistic health security with a strategic mission posture, right? So this is the kind of places which are there. Now this is at Mount Arafat. So a lot of pilgrims are here, and in case something happens, there is no way they can run down, right? Something happens on this mountain, it's a mountainous terrain, it's a rocky terrain, so they will be stuck there itself, right? Okay, and now you can see this is the central KAABA, and these people are circumambulating. So this is another place where there's a lot of chances of stampedes. So each and every place, like it be it Mount Arafat or be it this KAABA, we had to establish a medical mission, right? We had to deploy personnel. We had to establish some kind of medical aid at all these places, right? And there's no place to stand or move about, right? So what we did was we targeted these 5-6 things. First was the mission preparedness. So it was a challenging mission, and we had to ensure high operations throughput, because in such a scenario, obviously the kind of patients that will be coming will be overwhelming. Then we also had to ensure disaster health preparedness, and we had to conduct all the drills and standard operating procedures had to be in place. Then we had to establish health intelligence about pre-existing chronic diseases. Like we know after COVID, all of us know that people die more when they have got pre-existing comorbidities. So we had to establish this health intelligence. Then we had to establish this epidemic intelligence, right? For respiratory diseases. That time there was no COVID in 2016, but nowadays the Hajj is also having this challenge of COVID as well. Then we had to establish some real-time surveillance systems and also emergency response systems. So what we did was we established an echelon-based healthcare, right? And this was everywhere in all there are 2 cities involved. So both cities were covered, and all these different points were also covered, right? So there were mobile medical task forces which were catering to about 5,000 to 1 lakh pilgrims. There were static clinics. There were tent clinics, right? There was a mobile referral tent clinic. Then there were 3 secondary care hospitals, right? Where we could do some operations and we could admit the patients. And then we also had some referral and evacuation capabilities with the ambulance network, right? And we had to refer these patients to well-established tertiary care Saudi Arabian hospitals. So you can see this. Now this is the world's largest tent city. This is known as Mina, and this caters to that 4 million pilgrims will be staying in this tent city for about 5 days, right? See, this is the kind of road networks which are available in these 10 cities. So you can see that it's the road networks are also have to be very extensive, and even on these roads people are walking. So it's very difficult to move the ambulances or move anything because of all these crowds. That's why these are elevated, and grade separated flyovers have been there, and this clover leaf formation has been made. Despite of all this, it is overwhelming, right? So the research that was conducted in this kind of scenario was having an ambispective and an outcome surveillance design targeted at health intelligence, the extent of morbidity, mortality. This morbidity is the disease and mortality is the death, right? The mission challenges and the opportunities and interventions that can be planned. So what we did was, so in this moving assemblage, in all these buildings that you can see in between these buildings, then we found spaces in restaurants or any kind of buildings to establish our camps or the medical tents or the hospitals, because there are no special places for all this, right? the total patients that we catered was about 4 lakhs, right? The number of pilgrims that went from India were about 1.5 lakhs, but because they're staying for 145 days, so the total number of patients catered were about 4 lakhs. The doctor-patient ratio was about 1 in 1,000 approximately, and the paramedic patient ratio was also about 1 in 1,000. In this kind of a setup, there was an outbreak of food poisoning, which affected 90 pilgrims. There were many road traffic accidents, and there were a few fire incidents as well, right? So if you see the healthcare intelligence, a large number of these pilgrims are in the 70 to 100 years of age, which have got limited mobility. They cannot run, they cannot walk fast. So they need a lot of help, right? The data, I have compiled the data of these 5 years. So this can be seen well, so that you can see that the number of pilgrims are, and the number of pilgrims with chronic diseases were also quite a lot, right? If you see the incident reporting systems, then we see that there are a lot of other incidents as well as traffic accidents that were happening, such as the stampedes and fire accidents can also be there, right? Now, if you see the patient footfall, which comes to these clinics, so the static clinics, they catered for about 3,75,000 patients, right? The 10 clinics, about 5,000 patients. The mobile medical task forces, about 13,000 patients, and the rest were to the hospitals, right? Now, the total patients in healthcare, we have got primary care, secondary care, tertiary care, quaternary care, right? So these are the echelon healthcares. The first echelon was the primary care. Primary care is the basic tent kind of a setup, which is established everywhere, wherever the pilgrims are there. So that was the main place because it is the pre-hospital care, right? So this is the mainstay of care because that is the emergency care, and emergency first is to be provided at this level only. So total patients catered by primary care, right, was 3,92,000, and most of these patients who came had pre-existing diabetes, hypertension, heart diseases, as well as respiratory diseases. In secondary care, about 1,000 patients were there, and we had 3 Indian hospitals of 40, 30, and 10 beds, and we catered to about these 1,000 patients, right? And this, you can see that about 63% patient had to be admitted, of which about 58% were males and 63% were females. So females have got more conditions, more problems compared to males, right? And 55% patients were elderly, more than 70 years of age, right? And we catered for crush injuries, dislocations, fractures, right? Female patients used to come with abnormal uterine bleeding, so they just started bleeding on their own, and it was very difficult to control this kind of bleeding. About 15-16% patients had mental health issues, which is another big problem, because once the patients are psychotic or depressed or having anxiety or phobia, and they have got a lot of stress, then they also don't behave in a way which is required for that kind of a scenario, right? Some of them will have obsessive compulsive disorders as well, right? Then every patient is having a lot of stress because of heat, because of dehydration, because of no food, because of walking for a long distance, because of all these issues are there. They're exerted, right? Then there is dehydration, and most of them are in old age, and they have got multiple problems, right? So total of 2,000, more than 2,000 bed days were there of these patients, and the bed occupancy was close to 80%, which was also very, very high, right? The bed occupancy should not be very high because it affects hospital operations, right? And every patient was admitted for about 3.5 days for one episode, right? And overall, it delayed the definitive care. So this is the data, and you can see that a lot of diarrhea was there, a lot of heart attacks were there, a lot of respiratory problems were there, a lot of trauma was there, fractures were there. So these were the most patients there, and all of them needed some kind of help. Right now, if you see, respiratory infections were about 53%. That's the highest, and every patient was breathless, and there was a lot of overcrowding. So had COVID been there, it would have been a disaster, right? And there were a lot of patients with a lot of orthopedic problems like fractures or strains or sprains, and they were not able to walk. So total patients in tertiary care, which were sent to the Saudi Arabian hospitals, were only about 500, and most of them, 20% had heart attacks or some other respiratory diseases, right? And some of them had to be amputated, right? And because they had a lot of fractures. And so if you see the overall load here, so it was about 140,000 patients. And this load has reduced over the years because Saudi Arabia has already started using drones for surveillance systems, but not for actual patient care as of now. So you can see here in this slide also that there was Minna stampede and train collapse in the year 2015. Because of all these kind of accidents, also a lot of people died, right? So the all-cause mortality, that means that what I'm talking to is that the cause of death by all the causes combined is about 12 pilgrims per 10,000. So that's also very, very high, because they are supposedly not in the hospital, they're not terminally ill, but they're still dying there, right? And you can see that this is the kind of crowds. So in case of any casualty, any fracture happening, it is very, very difficult to evacuate the patient, or even it is more difficult to reach the patient. So how will the mobilization team reach that patient who is not visible? Because that patient will be sitting, or the patient will be lying down, and there is a chance that the patient can get crushed by this kind of moving assemblage, right? Now you can see this kind of scenario. If one patient gets heart attack, there is no way the ambulance can reach, or the doctors can reach, or any kind of help can reach. That is where drones are required, because at least the drones can identify that this is the place. Drone can send a GPS signal that this is the place where the patient is there, and the drone can also start early warning systems that other pilgrims can also start helping, because they are also not aware that the other patient is dying. So overall, the mission throughput was overwhelmed. There were a lot of operational stringencies, like what I already elaborated, and there was a question of interoperability, right? How to coordinate all the teams together. So that was a big thing. Then more than 90% healthcare personnel, they themselves were suffering from respiratory infections. So because of that, there was another challenge, because they were also sick. So they were also not available all the time. And there was a lot of physical, mental, and compassion fatigue in the pilgrims as well as in the healthcare teams. So now you can see what can be done, because this is a solution oriented scenario, but though it is a concept paper, so we can use lot of tethered drones. Now these tethered drones, the advantage is that they can be static and they can be deployed at one place, and there can be a monitoring station also. But the only thing in this kind of tethered drones is that the vehicle which is tethering this drone has to be there in place prior to the event. We cannot move this vehicle during the event, right? Similarly, we can have tethered blimps, or we can have helikites. These are very good, but the only problem is that they have to be static. They have to be there for all the time. They cannot be moved because of this kind of crowd, right? So what can be done with these drones? So we can enhance the surveillance. This already is being done. So Saudi Arabia, since past 8 years or so, has been using drones for active surveillance, right? That surveillance is being done, but the surveillance is not based on healthcare parameters. This is only for the crowd monitoring as of now. So what can be done is that we can be extended to the active patient identification. Then these drones can be used for delivery of emergency medicines at the site, or they can be used for delivery of medical equipment at the site, or it can also enable telemedicine, right? And overall, it can boost healthcare in difficult weather and terrain. So I'll just elaborate how we can do this. So you can see this. Now, this is one of the helikites, and this helikite is already established, and it is monitoring one particular area, right? So this one particular area is targeted for this helikite. Similarly, that there is one more helikite. So this is how it can be used, right? Now, surveillance can be done for active patient identification. Secondly, if there is overcrowding, that can be seen. Now, drone can also establish a warning system. So like it can have lighting systems that, okay, which can laser-based lighting system, which can pinpoint to the patient or the area where intervention is required. Then we can have drone guided search movement and direction. So the moving people can also be guided by this drone based warning system that don't move in this direction. There's a lot of search there, right? But the caveat is also there with all these drone based systems, that we need expert drone pilots who know what is going on in the Hajj pilgrimage, who know what are the problems that can be there. Then there can be drone accidents, like the drone can fall or the drone can crash. So in that case, we need to have a secondary drone. We need to have a backup drone. And we also need to educate the patients that this kind of drone will be doing a surveillance, because these patients can have drone psychosis. Like they see a drone which is monitoring them and they will go psychotic. So these are the real life problems which is there with humans, right? Then the second thing is drone delivery of emergency medicines. So what can be done? We can deliver adrenaline, painkillers, anti-asthmatics. But again, the caveats are, we need expert medical personnel. We need support logistics. Like if the adrenaline is there, we need a syringe also to administer it, right? So it's not just the adrenaline. We need a lot of other things which have to be catered. Then we need to do some kind of crowd education so that they are able to support the patients, because a lot of them, they don't understand what the patient is going through. So they just run away, or they will just do no kind of support is there. They will not move, so that the access to the patient can be secured. Then the third thing is that we can establish drone delivery of medical equipment, like automated external defibrillator. So suppose a patient has got a heart attack, or a patient is having a failing heart. So in that case, this automated external defibrillator will be handy, right? But Now we need medical doctors at site who will use this AED. Not everyone can use it. So some paramedics who are trained enough, they can use it. Otherwise, we need doctors at site. Now, how do we position those doctors? Because we just had about few doctors, 150 doctors. So it is not possible to place one doctor at each and every site, right? And the patients, that they have got a different language, like because they're from so many countries and they're all mixed up. So language barriers are also there. Similarly, we can deliver splints, we can deliver bandages to stop bleeding, and we can deliver some kind of airway management devices, like we can deliver the pumps for which are having anti-asthmatics. So all these things can be done with the drones. Then what we can do is that we can do drone-enabled telemedicine. Now, this is very, very important because a drone can monitor the patient. Even if the doctor is not able to reach there, the doctor can sit at one monitoring station and can guide the patient by himself, or a paramedic who is there with the patient to what is to be done. This is one very, very big thing, because if we have got an army of drones everywhere, then these drones can be deployed to look for multiple functions of the patient and monitor the patient there itself, right? Or just take the photo of the patient and send it real time, so that we know that, okay, the patient is how breathless the patient is. A doctor can, sitting at a monitoring station, can monitor the respiratory rate of the patient just by the drone footage. So all these things can also be helpful, right? But we need experts at both ends, and there are a lot of dead space limitations because of these mountains. So because of the mountainous terrain, there are a lot of dead space limitations, right? So you can see these are the tethered drones, and all these drones, they have got different kind of capacity. The payload capacity is different, the altitude range is different, and the kind of anchoring that is required, that can also be different, and this can be enabled in the HAJJ infrastructure and the HAJJ geography, right? So now you can see these are the, so this looks very good on paper, right, on the concept, but stationing a vehicle or all those mountainous places is not easy. That's very, very difficult, right? So, but still, if we are thinking aloud right now, maybe in future we are able to position all this, right? And so far, what has been done, right? So far, what has been done in HAJJ is that these drones are being used for monitoring, observation, and coordination. They are used for surveillance, but crowd surveillance, not medical surveillance as of now. They're used for lighting and everything. They're used for 5G coverage and emergency communications and maybe disaster relief, but on ground, medical relief is far and it's just far and few. So that is where we need to intervene, that we should enable this drone surveillance and drone operations to boost the medical capacity, right? So the recommendations what I have for this kind of scenarios, not only for HAJJ, in India, we have got Kumbh Mela, which is bigger than HAJJ, right? We have got so many events which are much bigger than HAJJ. At least 4-5 events are there in India, but which are not yearly. They are every few years, but they are bigger than HAJJ. So here, drones can boost preparedness. Yes, we need more doctors, we need more paramedics, more ambulances, more medical equipments, but we need more drones as well. Secondly, the clientele has to be young, healthy, knowledgeable, and disciplined. They should be attuned to the presence of drones, and they should know how to use drones for their own benefit and for people's benefit. Then we need to boost the health systems with drone adaptation, which is again one big area which needs improvement, right? Apart from that, we need a lot of risk modeling by static modeling and dynamic modeling. We need artificial neural networks, right? It is not just a one thing. We need to blend technology as with healthcare, which is in itself is a big thing, right? And we need a lot of telemedicine and decision support systems, right? So without the drones, I have published about 5 papers in this HAJJ medical systems. This was the first paper. So, and this has been widely cited. This is the second paper. This paper is basically on the administrative aspects of how have we built up all these capacities, right? Then this is the third paper on operations throughput, because we have a lot of patients in one point of time. So we are not able to cater to them, all of them. So operations throughput and the concept of golden hour is questionable in this kind of health system, which is in tents, right? So this is to boost, how do we boost the operations throughput in this kind of a mass gathering medicine scenario. Then this is the fourth paper on emergency response to heat illness, right? Because a lot of people came with dehydration, and they came as unconscious, and they were just having the effects of heat, right? And this is another paper on the kind of obstetric things, because a lot of these women, they go there and they deliver also during the HAJJ. And you can just imagine, I will leave this to your imagination, that a lot of people are dying, a lot of people are having so many problems, and there are women, pregnant females, who are delivering babies during HAJJ, and they have to be taken care of. Both the mother as well as the babies have to be taken care of. And this is then, and a lot of abortions, they keep happening, right? So all these things, like in 1 year, there were 20 vaginal deliveries, right? And there were 2 cesarean sections and 32 abortions. Just imagine that all these things happening in this kind of scenario, because people come from different countries. They have no concept of the fact that they should not be delivering during Hajj. Rather, they think that they should deliver during Hajj because it is considered auspicious. So people coming from third world countries, that includes India as well, and other countries, they do this as well. So we have to cater for these kind of patients as well, right? So these are some of my references which I've worked through this. And and this, there's some ref packs which are like, this paper has been presented, the similar paper without drones, in the WHO conference on mass catheter medicine in Hyderabad. And this papers have been widely cited in Times of India as well as other newspapers, right? And both the Indian guidelines and the Saudi Arabian guidelines, they have been modified after the publication of these papers, and they have incorporated all these scenarios, because there are few papers on Hajj systems earlier than this 2016 paper. So with that, I finish, and I will leave the forum open for any questions, additions, or comments.